Hi, I'm Shabir Imber-Safdar, the Executive Director of the Partnership for Safe Medicines. We study counterfeit medicines and the policies that increase or reduce those risks to the American public. Now, all of us of a certain age learned from Schoolhouse Rock the process that takes an idea to become a bill and eventually a law. But they didn't talk about what happens after that, and some laws require regulations spelling out more details before the American public can use that law. And that's what happened back in 2003. Congress passed and the President signed into law the Medicare Modernization Act, which made many major changes to Medicare, but also had a small provision about importing drugs from Canada. That provision said that before anyone could bring in any medicine from Canada, that they had to study the safety and cost issues. Then the Secretary of HHS had to certify to Congress that they could do safety and savings effectively, and then issue proposed regulations for public comments. Well, the task force did that study, and that task force included current Secretary of HHS Alex Azar, and they concluded that it would be difficult to import medicine from Canada safely or cheaply enough to save money. And then, for the next 16 years, no Secretary of HHS was willing to take those risks, whether they were appointed by a Republican or a Democrat. But then in December of 2019, this administration skipped those two steps and issued draft regulations for public comment for importing drugs from Canada. Over 1,200 comments were filed by the March 2020 deadline, and PSM research staff read them all. We produced an infographic about what we learned, but in the process, we actually ended up learning some very surprising things about the regulatory process and who had things to say about this. The most shocking thing is that the federal government of Canada filed comments. I didn't even know that other governments knew how we did public comments or regulations, or if they've ever even filed comments instead of just calling the White House. But the government of Canada filed formal comments to go on the record. And the comments were unequivocal. They said the proposal couldn't possibly reduce drug prices because Canada simply didn't buy enough medicine to make a dent in American demand. And then they pointed out that it would endanger Canadian patients. For Canadians who are normally way more subtle and polite than this qualifies as a sick Canadian burn. Procedurally, we learned that you can't just issue a proposed regulation. You have to filter it through all sorts of other processes first. Since this is one of those ideas which isn't well thought out to begin with, the fact that the rule skipped all sorts of other important steps, it was not entirely surprising to us, but we just learned what they were. It appears that the White House skipped the step that requires it to examine a rule's impact on regulatory flexibility, unfunded mandates reform, 3 executive orders, which includes one that require that you assess what impact a rule would have on Native American tribes, the E-Government Act of 2002, which requires that you assess potential privacy issues of the proposed rule, and all of those items were skipped. Then finally, there was a really glaring problem. The law allows the administration to issue draft regulations once it has certified to Congress that Canadian drug importation is safe and would save money. But they didn't do either of those things first. They just skipped those steps and went straight to a draft rulemaking, and honestly, you'd think that would tank the whole thing. Not surprisingly, other Canadians who filed comments didn't like this either. We've been hearing from Canadian healthcare workers and patients for a while now that they didn't think that this idea was one they were in favor of. But many of them came out and forced to file comments, including the Canadian Society of Hospital Pharmacists, the Canadian Pharmacists Association, the Best Medicines Coalition, which is a coalition of Canadian patient groups, and Innovative Medicines Canada. In addition, the 3 major prescription drug distributors, AmerisourceBergen, Cardinal Health, and McKesson, all submitted comments saying that drug importation is a threat to patient safety and the security of America's drug supply chain. When the people that have basically built the secure track and trace system tell you that you've broken it, that is definitely not a good sign for your proposal. If you're not familiar with track and trace, it's a system that every part of the drug supply chain in America has spent hundreds of millions of dollars implementing. It puts a trackable barcode on medicine when it starts from the factory floor. And then you can scan that barcode as it moves through every pair of hands that touch the medicine. And they keep a record of that barcode. It becomes easy to check the history of a medicine. What the draft regulations propose is that you simply slap a barcode on it when you buy it from Canada and bring it into the U.S., not at the point of manufacture. It's not track and trace. The Medicare Modernization Act requires that consumers must see significant savings from a drug importation program, but there are no guarantees in this proposed rulemaking. Multiple organizations that focus on reducing waste of taxpayer dollars wrote in to express their very grave concerns, including the Citizens for Government Waste. PSM has been tracking the Canadian drug importation program in Colorado since they passed that law last year. They've burned about $500,000 so far, and they've appropriated another $1 to $2 million to spend. And yet when we analyzed their program, our research team found that Colorado's healthcare system could save over $40 million immediately just by buying generic versions of the medicines that people take now, and without having to recreate some version of the FDA in Colorado. So we think that Citizens Against Government Waste and the other conservative groups have a really good point about protecting taxpayer dollars. Also filing comments was the association representing every state's Board of Pharmacy. In many states implementing Canadian drug importation, they've been ordered by the legislature to figure out how to license foreign entities. None of the boards of pharmacy that we've spoken to are excited about that particular challenge and the legal impediments to doing so. According to the National Association of Boards of Pharmacy, the proposed rulemaking relies heavily on the state boards of pharmacy to provide oversight, but the FDA has not involved state pharmacy boards in any stakeholder discussion, so they don't really know how they're going to do that. They also said there's a shocking lack of involvement by a board of pharmacy once the state's program has been implemented. For drug importation to work, patient safety must not be sacrificed, and consumers must see significant savings. The Duke Science Regulation Lab examined the top 20 grossing drugs in the U.S. in 2018 with regards to this proposal and found that only 4 of them would be candidates for drug importation. Drugs like Humira, Enbrel, Keytruda, Eliquis, Lyrica, and Avastin were just a few of the drugs that would be excluded from drug importation for reasons such as being a biologic or a controlled substance or being administered intravenously, which are all prevented from being imported by the 2003 law. These aren't the most frequently prescribed drugs in the country. In fact, of the 20 most prescribed drugs in 2018, every single one of them was a generic. And generic drugs make up 90% of the prescriptions filled in the U.S. And they're often cheaper in the U.S. than Canada. We confess, we knew this last one already before the comments were filed. I'm not sure how often this happens, but a former FDA Associate Commissioner named Peter Pitts submitted a comment to the current FDA staff and commissioners reminding them that drug importation has been tried before and every single program ended in failure. Failure to provide savings, failure to have enough people interested in the program to have it save money, and even failure to ensure patient safety. What's next? There's actually no timeline for when the administration has to respond to comments. And they have a lot of flexibility. They could withdraw the rule, which they should, or they could release a modified one, or they could sit on it forever. But no matter what they do, we'll be tracking it at www.safemedicines.org. For the Partnership for Safe Medicines, I'm Executive Director Shabir Imber Safdar. Thank you.